so much, everyone, for having me today. I'm really thrilled to be here on behalf of ADAA. I am a board member for ADAA and a longtime member, and it's a wonderful organization. I'm glad you're all here with us today to learn about this very important topic. Just a little bit about, you heard a little bit about myself. I'm a clinical psychologist, and I've treated youth with mood disorders and people with mood disorders, depression for a very long time. And I would hoping today to just dispel and give some of the really important information about depression particularly, but we are going to talk a little bit more about the whole spectrum of disorders in that realm. And really to have this in the end, we're going to take some time to have question and answer, have it be interactive, so we can really get a sense of what you are looking for in terms of information. So again, without further ado, I'm going to move on. Let me give you a sense. Maybe I will move on. Let's see 1 second. Got some technical difficulties. There we go. So today's topics, this is just a very broad overview. We're actually going to be getting into some other topics too, including how to address depression with your child, how you're going to deal with the topic of suicide. We are going to be talking about that today, so I want to give you that advance notification. And then just also how to deal with schools, how to deal with finding treatment, getting the best treatment approaches. And again, we'll have a question and answer at the end. All right. So you may be on this call as a parent, you may be on this call as an educator, perhaps even a clinician. The question that often comes is, why are kids, especially teenagers, they are the ones that are known the most to be the moodiest. Why are they so moody? What's going on? Why all the distress? Well, being a kid's actually stressful, especially in this day and age. Comparatively to when I think a lot of us were young, it is definitely a world that is more complicated, especially with the internet, social media, and managing all the demands of life. So as much as I think adults also have a lot of stress, I know I do, but kids are also feeling it. We're all in this together, actually. So, we're actually better equipped to handle this stress. They have less experience doing so. So that's part of what we want to help them with. Okay, so where does this stress come from? Well, first thing that's going to come to mind for everyone is school. What happens in school? They have to deal with homework, managing schedules, dealing with organizing everything, especially depending on how old they are, their relationships with kids and their friends and schoolmates. It takes a lot of work. And there's the social aspect, both in school and out of school. And then, of course, parents. I should say here parents and families, but particularly relationships with parents can be wonderful and can also be stressful. Social media. There's a lot of information out there, and more coming out about how complicated social media is for our youth. And both there's benefits and there are definitely problems. And so we can't get into that so much today, but there's a lot of information out there you can access, and just be rest assured this is stressing our kids out to some degree. And then we have some kids who have to work. Some kids are getting extra jobs, especially in high school or as in college, to be able to support themselves. So that's an additional stressor. And finally, the world, as I mentioned before. I don't think I need to explain. So we're going to keep in mind that kids experience stress. So what does that have to do with depression? Well, first, let's talk about typical behavior for teens. And I'm going to go back and forth in this presentation between teens and children, and kind of sometimes lump them all together and sometimes separate them out. And young adults are actually part of this too. So just be rest assured, we're going to try and represent the whole youth spectrum, but every now and then I'm going to talk about a particular group to emphasize a point, and this is one of them. So in typical teenager behavior, we have a healthy balance of friendships and relationships, healthy self-development, we have good school performance, and we really are just having a kid who generally most of the time is doing okay. Kids have ups and downs just like we do. Their moods go up and down, but generally speaking, they are doing well. And I wanted you to keep this word in mind. They are functioning well in different areas of their life. So what also happens for teenagers is they can be really moody. They have a lot of brain changes going on, which we'll talk about a little later. And they can get depressed, they can get down, they can get demoralized. And a lot of the time parents will say, I have no idea what's going on and why this is happening. That's typically, that's your teen. Some teens are more moody than others. And it's funny because I've had parents say, my kid was not this moody as a child, and then they turn 12 or they hit puberty, and all of a sudden, yes, that happens again, related to the brain changes. Finally, there's changes in developmental and behavioral tasks. You're going to see your teens becoming more different. Their sleep schedules are going to be a little different. Sometimes they stay up much later. Sometimes they don't get as much sleep, or they're sleeping for 12 hours. And you're like, are you ever going to get out of bed? Sometimes they are having increased levels of stress, as we've been talking about, from really a lot of educational and vocational goals. They have changes in attention, how much they pay attention, how much demands are on their attention. Their motivations change, their goals change. And finally, teenagers, as we know, are much more likely to be risk-taking. Even the most unrisk-taking kids can take risks at times, because this is the age in which kids are trying different things out. Another developmental task is separation from parents, which many parents are definitely aware of, and how that can impact. And finally, increased reliance on peers, self, and others. Okay, so the first thing I'm going to do when talking about depression is, I get this question a lot. How do you know a kid is depressed? What do you see that concerns you? There are really 3 different things you have to pay attention to. Okay, it is especially for a teenager, but you can see this in preteens. You can even see this in certain younger kids. They're not necessarily going to be happy all the time. Their moods are going to swing depending on what's going on. But when we're talking about clinical depression, we're not just talking about sadness. We're talking about a clinical disorder. And let's distinguish what a mood swing is versus depression. So first of all, the duration. How much time has this been going on? If it's a few days that they've been sad or moody, or it's on and off here and there, that's not depression. A lot of the kids use the word depression at this point to describe this, but that's not clinical depression. For what we call major depressive disorder, it actually requires that the kid be sad or irritable most of the day, every day, for at least 2 weeks. So it's really a more of a change than just a fleeting thing. However, some kids have much lower grade kind of presentations where they're sad a little bit, but they're doing okay. So sometimes you're gonna hear me say this a lot as a parent, as an educator, or however you're representing kids today. You got to use your gut. You got to really go, something's off with this kid, because I know they're different than they used to be. So duration, how long have the symptoms been present? Severity, how intense are these mood changes? Is it just here and there, or is this child having temper tantrums where they never did before? Is this child becoming so angry? Are they starting to hit things? Are they doing other behaviors that you haven't seen that seem really extreme? We want to pay attention to that, and you're going to see that over time. Finally, functioning. That word again. How are we all have to function in this world. We all have to do our tasks. We all have to keep going and do our work, get school done, be with our families, all, every errand, order things on Amazon, everything you can possibly imagine, right? So how are they different from their typical selves? Is something off? Like, you say to yourself, something's not right here. Again, you want to pay attention to that. And finally, I want to be really clear that both adults and children, they often don't recognize that they're depressed. So I've had parents say to me before, my kid didn't tell me that they were depressed. And I would say to them, they probably didn't know. Their kids are better educated today on depression and anxiety and a lot of these things because of social media. And sometimes they still don't have an awareness that it's actually happening to them. They just know something's wrong. Okay. So I'm just going to go a little bit into the problem of depression in teenagers. It is a really significant problem in the world. So there's some statistics we want to know. For example, we know that 14.7% of the US population ages 12 to 17 has experienced a clinically significant, what I've been talking about, episode of depression. And only 40% of those diagnosed receive treatment. Granted, what's really the good news here is that 40% number is definitely up from before. That being said, we have a long way to go. Developing depression in adolescence increases the risk of developing chronic and recurrent depression in adulthood. If there is anything that I ever say to parents, to educators, when they bring a kid in and they're like, I'm not sure that this is right to bring them in so soon, I always say it is better to be safe. It is better to be proactive because the risks of not treating disorders early on and how they can grow into chronic situations, it's significant. For example, when you have a kid who is an elementary age school kid who is diagnosed with anxiety, that automatically increases the likelihood that they could develop depression in teenage years. It often converts. So to be able to get to that anxiety early on may help to stave off depression. So these are some of that we always want to be on the forefront of recommending treatment. Of course, along with depression becomes the increased risk for suicide. We are going to go into that in more detail down the presentation. And the thing you should also know about depression is it co-occurs. It is, you have it at the same time with other disorders, especially ADHD, anxiety, substance use, learning disorders, trauma. Even I didn't put trauma, but that's in there too. So there's a lot of different disorders that happen with depression. It's not always by itself. In fact, anxiety and depression, ADHD and depression, it seems like they love to be together because they often present together. Finally, we do have treatments for depression. They are good treatments. They are not perfect treatments. So a lot of people feel better in the short term, 60%, still not high enough, and 30% quote unquote recover. But people will often have relapses of depression throughout their lives. And so what we want to do again is youth is the time in which we really want to youth is the time that we really want to be able to intervene right away. Okay, how is depression labeled in the world? And I'm going to give you a little bit, for those of you who are not clinicians or don't have this knowledge, just kind of the vernacular of what we talk about with depression. So you hear people label depression as sadness. Sadness is a symptom of depression. It is not the same thing as depression. Moodiness and irritability. Irritability and sadness, I really want to say to you, are some of the most prominent features of a clinical depression. Sometimes kids, that's something you should really understand in youth, is that sadness presents a lot and irritability often presents just as much, and maybe not at the same time. So you can have a kid who's super irritable, but not saying that they're sad or experiencing sadness, still could be depression. Really important to keep that in mind. So let me talk about the different diagnoses. I'm going to go through them super quick. So first is, I've already talked about, is major depressive disorder. And these are all in the DSM-5, which is our Bible for psychiatric disorders, at least in the United States. There's the ICD as well in the world. And so major depressive disorder, I've talked about that, a good number of symptoms over 2 weeks or more, and it really causes significant impairment in functioning, like I've talked about before. Persistent depressive disorder is what has been referred to as a low-grade depression. It's still pretty significant, and in youth, it's the presence of certain symptoms of depression for at least a year. And again, it can really go undiagnosed because it's sometimes undetectable, but again, it has to cause significant problems in functioning. A common diagnosis you see in psychotherapy practices is this adjustment disorder with depressed mood. It's a depressed mood usually related to some kind of event that's happened in a person's life, or change or transition of some kind. Then we have bipolar disorder. Bipolar disorder is a type of mood disorder, as is depression. Whereas in bipolar disorder, you have a person who has both depressive episodes and what's called manic episodes, which I'm sure many of you are familiar with, which is the idea of a person having too much energy, becoming more impulsive, having less sleep, more on the go, but in a very dysfunctional way. So it's hard to boil down bipolar into 2 seconds, but that's basically the idea. And it's a disorder that requires significant treatment as well. We have this category, which if you ever get an insurance bill or something like that, you're going to see unspecified or other specified. That means that there's some symptoms of depression, but not enough to diagnose. A lot of kids, these days, we're really concerned about premenstrual dysphoric disorder, and that is very much mood related to females that have their periods, and their mood symptoms are related and have been tracked in such a way to define that. And finally, we have disruptive mood dysregulation disorder. This is typically a disorder given to children that are having significant temper tantrums, mood dysregulation, behavioral problems, and requires particular treatments. So these are the types of things that your clinicians talk about when we're discussing mood disorders and thinking about depression. These are all the different things that we have to kind of siphon through to figure out what's happening. All right. I also didn't mention, I didn't put it on here, but grief is also another thing that can happen where people experience what seems to be symptoms of depression. So I should mention that as well. Okay. How do we currently diagnose? So when you go to a clinician and you suspect that there's something going on, we have a lot of instruments that will help us. We have what are called structured interviews that ask a series of questions that allow us to figure out what the diagnosis is. And one that you may have heard of before is called the case ads. We also have checklists that a person can fill out their self-report, and they're symptom oriented. So we can get a better sense of what the person is experiencing. Of course, that's going to depend on how honest the person is when filling out the form. Okay. The thing is, our diagnoses, we can label what is happening, but it doesn't predict the course of the disorder or how a person's going to respond to treatment. And so there is research going on to figure out genetic factors or biomarkers that use imaging to be able to figure out if a person actually has depression. We can't just give a test and say this person has depression. We'd like to get there. Okay. So some warning signs of depression in teenagers, and I have a different list for kids. They're very similar, but there's some different varieties. So, and a lot of these warning signs, I should say, also apply to young adults and adults. What you are seeing often, again, is frequent feelings of sadness and hopelessness, irritability, anger, hostility, changes in eating and sleeping habits. Can't tell you enough how important this is in terms of a kid who maybe was sleeping 7-8 hours a day and now is sleeping 12, whereas now is sleeping 4. A kid who has a healthy appetite who all of a sudden is eating a ton or is eating nothing or is eating very little. These are big changes that you want to pay attention to. You're also, I should mention, and it's important, we always think about this as clinicians, we're also trying to make sure that there's nothing physical going on, that there's any kind of medical disorder that's contributing to these things. Tearfulness or crying, feelings of worthlessness or guilt. And as I'm going through this list, it should be very clear, you don't have to have all of these, but you do have to have a number of them. Physical symptoms, aches and pains with no explanation, especially see that in little kids. Withdrawal from friends and family, loss of interest in usual activities, fatigue or lack of energy and motivation, difficulty concentrating, diminished academic performance, and of course, thoughts of death or suicide. These are all warning signs that there's something going on. For younger kids, there's additional things to look for. A lot of, like I was saying before, a lot of irritability and temper tantrums, much more so than a kid has had before. Loss of interest in playtime or plans or time with friends, play dates. They just don't want to go, or they go and then they're angry or they get into fights with their friends. Things like that happen. Low energy, fatigue. I'm bored. I'm so bored. I'm so bored, where they don't usually say those kind of things. Difficulties with attention. Really, a kid who, and a lot of the times, especially with little kids, this will get misdiagnosed or additionally diagnosed as ADHD, but it's really a depression, or sometimes it's anxiety. So these are things that they're difficult to tease out. I mentioned already physical complaints, headaches, stomach aches, any kind of those kind of random medical complaints that kids have that don't seem to have anything associated with, those are often emotionally connected. Anxiety, mood, depression, these things, it's important to pay attention to. And finally, negative self-statements. And that actually could have been in the list for adolescents and young adults as well. But especially little kids will sometimes be, they say it more simply. I hate myself. I don't want to be here. No one loves me, things like that. So that's why we put that there. Okay. School manifestations, you see lots of different things. Difficulty concentrating, forgetfulness, really more difficulty planning and organizing. Their grades just start to tank. And they don't do well like they were before. They have no interest in their homework comparatively before. They isolate or withdraw from other kids, and they are having their relationships are disrupted in some kind of way that wasn't happening before, such as like increased fights or arguments. this rejection sensitivity, you'll see this at home too, but this just any small little thing that that one says, it hurts their feelings. And some kids are very sensitive and that can happen, but again, you want to pay attention to what were they like before. And it can be tricky when you don't know a kid that well. You're an educator and you're just meeting them like this time of year, you've had the kids like a month, maybe you know them a little while, but it's hard to know sometimes what they're really like. And finally, complaints of aches and pains with no physical explanation, lots of trips to the nurse's office, lots of requests to go home, that kind of thing. All right. So a couple of risk factors for adolescent depression that we really want to keep in mind. And this is also for youth depression as well. A family history, this is genetically linked. Family history of depression is a big factor, especially having a parent who's had depression or a depressive episode or a mood disorder or anything like that. Really important factor. For adolescents, they having a mental health disorder in childhood or pre-adolescence. Again, anxiety disorders, ADHD, even previous depression. Serious negative life events or series of negative experiences or stressors that are very impactful. One of the things you have to keep in mind with any kind of mention of this is that it's also the perception of how the person sees it. So if as clinicians, we hear, oh, your parents got into a car accident and they were hurt. And a lot of kids, you would just assume that's devastating for a child. It is, but certain kids respond in certain ways and certain kids can be more resilient and it affects them, but not to the degree that it starts to impact them in a negative way. So it's really important to understand the child's point of view. Finally, these ineffective coping skills and negative thinking patterns, these start from an early age. And a lot of kids, some kids are equipped to be able to handle difficult situations, but a lot of kids, none of us come with owner's manuals. So a lot of them don't unless they're specifically taught. And by that point, the depression has already started to arise. Okay. So what causes depression? We don't really know. We don't have a full understanding of what causes depression. However, there's a lot of good scientific research out there, but there's no significant explanation. Some of the things we keep in mind, genetics, I've already mentioned that. Differences in brain functioning. So we, for example, know that adolescents have structural differences in their brains compared to adults. Besides the shape, besides the structure, they also have hormone differences and different levels of neurotransmitters. So these things are really important to keep in mind. And there's a lot of research going on to figure out what impact that has on the brain and then behavior. I've already mentioned traumatic early events, stressful life events, and learn patterns of negative thinking. One thing you can keep in mind as an adult is that if children model us very, very closely, so they watch us. So if we're expressing negative thoughts, if we're looking at something in a negative way, they're going to follow that. So we have to always keep in mind how we're presenting to them. Okay, so action steps are going to be a part of this presentation today. Just checking on the time. Okay. So the first thing we want to know about is, how do you talk about depression with your child? Let me take a quick sip of water. Okay, so because a lot of parents don't know how to start, or a lot of educators don't know how to start. So the first thing, and I'm also going to be talking about how you talk about suicide in a little bit, and a lot of these are going to overlap. The first thing is you can offer support. I'm here for you. If they're like, I don't want to talk about it. Okay. Whenever you're ready, I'm here to talk about it. And that comes along with being gentle in that same way. I'm here to talk about it. I know you're struggling. Don't give up, even if you keep getting no's. Sorry about that. Address the elephant in the room. I know you're feeling bad. I can see it. This is what I'm seeing. Is this correct? And again, one of the things I always tell parents is that sometimes it's better to have this conversation in the car, walking next to the kid, somewhere where you're not looking directly at them, because a lot of kids will open up in that way versus when you're sitting right in front of them, looking at them. It's super intense and they just can't handle it. So listening without lecturing. A lot of people want to problem solve for kids because they don't want them to feel bad. Your job when you talk to a kid about depression is to listen to what they're saying and not just jump to advice. You want to validate them, show them that you understand. You want to be honest. If they have questions, you don't know all the answers of why this is happening or even how to get help, but you're certainly going to try and work on it. As a parent, as a teacher, you want to maintain the typical activities. You don't want to just start saying, okay, you don't have to do anything because you're feeling this way. No, we're doing the opposite. We want them to be engaged and active because that helps to even like help the depression, lessen the depression, or even just keep it at the level that it is. As a parent, as an educator, anyone else who's with a child, you want to take care of yourself. We constantly refer to the plain analogy of you have to put the oxygen mask on yourself before others. So it's really important to keep that in mind. Oh, we have a total typo there. There was something that's supposed to be something else. I apologize for that. So that was yeah, forget that. Well, that is a disorder we have, so we'll fix that later. But you get the main points of how talking about depression with your child, it's important to open up a dialogue and not have it just sit there and be afraid that if you talk to them, it's going to make it worse. Okay, I'm going to jump into suicide. So again, I know sometimes this topic is really tough for people. I'm going to keep it nice and straightforward, and just keep that in mind. So suicide in youth, it is a very big problem in the world. Second leading cause of death, children, young adults, ages 10 to 14, 25 to 34 in the US. Third leading cause of death, ages 15 to 24. And these statistics, they flip-flop. You know, when I was updating this slide deck, the second, for 15 to 24 used to be the second leading cause of death. At one point, it was a first leading cause of death. So it really does kind of go back and forth. Main methods of suicide, firearms. That's why we talk about guns a lot, because they really are the main thing for people across the board. Poisoning and ingestion or drug overdose, and hanging and suffocation are the top three, essentially. Gender differences. It's important to keep in mind when you're working with kids. Females attempt more. Males complete suicide more frequently. I don't know that we have, I don't have stats on transgender youth per se, but what I can tell you, as it says below, is that half of LGBTQIA plus students report having considered suicide. So just being in that group increases the likelihood. American Indians, Alaska Natives have the highest completion rates, followed by white adolescents, but that doesn't mean it's not a problem for all groups. And it's really important that you understand that 100 to 200 suicide attempts per completion, meaning there are a ton of people attempting suicide in some kind of way every single day. I think I read some statistic that there's something like 3,700 attempts reported every single day, and that's just the ones that are reported. So a lot of people are suffering. Couple things to keep in mind when you're thinking about talking about suicide for youth. And again, suicide being such a prominent symptom of depression. The risk factors, mental illness or substance abuse in the person and in a parent, okay? Previous suicide attempts, firearms in the home. I already talked about parent depression or mental illness. Non-suicidal self-injury, often referred to as cutting, as burning, scratching, those kind of things. That is not the same as suicide though, okay? Just sometimes those things get mixed up. It's why we call it non-suicidal self-injury. Exposure to suicidal behaviors in others. So there is, when you hear about suicides, it can for certain people increase the potential for an attempt. Sexual orientation, physical or sexual abuse. We should also update that again to be the LGBTQ group. Significant academic difficulties, physical disease and injury, and of course, the social milieu and media, how involved they are in that. Protective factors, family connectedness, school connectedness, positive peer relationships, increased self-esteem, like a kid who generally is pretty good in their self-esteem but is not feeling great. Goals for having a goal for the future. One of the things I always ask kids is who are at risk for suicide or stating suicidal thoughts. What are your goals for the future? Who is the most important to you in this world? Reasons for living. That's exactly what we're talking about. We want to identify why stay alive. Okay. Oops. So is your child thinking about suicide? There's severe warning signs. There's concerning warning signs. The thing that happens a lot, which you will hear, and I'm sure many of you have heard before, is that people miss signs because they don't see them. It's not that they're not always even not aware of them. They are aware of them. It's just so hard to grasp that someone is experiencing this. So severe warning signs, writes or talk about wanting to die, severe withdrawal, gives away personal possessions, online searches regarding suicide. And I don't have time in the scope of this conversation to talk about this, but there's research done by a man named Igor Galyenker, who talks about suicide syndrome, which basically when someone gets focused on the intent to die, they actually really get so zoned in and they can't see outside of it. So when we're talking about these severe warning signs, this is what's often happening. Concerning warning signs, I'm not going to read through all of these right now, just know signs of depression, extreme mood changes, sudden changes in behavior, and more impulsive behaviors. They're just acting differently, but just even the presence of depression really should have one paying attention. Okay. Actions to take as a parent or as a person who works with kids or a caretaker, any kind of things. These are steps that I'm going to go through rather quickly, but they're important to keep in mind. So the first thing is, if you suspect that a child is thinking about suicide or is in danger of some kind of way, even though you're not a clinician, you can still assess for safety. You can still help to determine if the child needs more assistance or if they can be alone. So the thing that I get asked a lot is, doesn't talking about suicide actually promote suicide? No, it does not make a person try to kill themselves. We want things to be out in the open. Okay, so don't be afraid to ask, be direct. Are you thinking about killing yourself? Are you having thoughts of suicide? Sometimes I'll say it more gently. Have you had thoughts of dying? Have you had thoughts of not wanting to be here? Sometimes that helps to get things a little bit more open. As a clinician, when we assess for suicide, we ask four different areas really. Thoughts. Are they having thoughts? Do they have a plan? If they have a plan, we're getting into a little bit more of a serious area. Do they have means? Is there a way that they are planning on doing it, and do they have access to the means for it? And then finally, do they have the intent? If a person has a plan and has the means, or even just has a plan and maybe isn't so sure about the intent, that may require a visit to the ER or immediate seeing their clinician to be able to assess if further interventions needed. But sometimes if people have suicidal thoughts all the time and don't act on them. So it's really important to always ask for help from someone else who's a professional who can help in the situation. And this is important to recognize what the levels are. As you're talking to a child, show concern, stay calm, encourage them to express their feelings if they're willing to, trying to validate them, try to not judge, try to not lecture, try to not convince them to live. Don't try to explain to them why life is so good, because that could be super invalidating to someone when they're feeling terrible. Try not to offer quick solutions. You want to listen. In fact, it's helpful to often say, I'm not going to fix this whole problem right now. Let's try to figure out a way to make you feel better now. Okay. Offer hope that there's other options from suicide. And again, the best thing to do is listen. Okay. If you feel your child is safe, or the child is safe that you're working with, offer the child company. If they want space, you can determine if you're going to check on them a certain lengths of time to make sure things are okay. You want to clear the house, the access, or wherever you are, to weapons, knives, razors, anything that could cause harm. If the child's in treatment, you want to contact a therapist. You may need to go to the ER. We have now a national suicide hotline, and that is available 24/7 for people to call. I've had parents say to a kid sometimes, if you don't want to talk to me, will you call this? And some kids have said yes, because they don't want to talk to their parents. It's a very shaming experience for some kids to admit to their parents that they're having these thoughts. Okay. Treatments. We are getting there. So treatments for depression in youth. We, in ADAA and organizations I work for and have worked for, we really recommend a combination of evidence-based treatments and medication to treat depression. Sometimes medication is not needed. Sometimes it is. Often it is, but it's important to keep in mind that this is the gold standard of care for treatment of depression in youth. So that includes cognitive behavioral therapy. That is, if you're not familiar with that, that is a treatment focused on changing your thoughts and your behaviors to change your feelings, to alleviate symptoms. And it also part of behavior activation is part of a lot of these treatments, not just CBT, but it's the idea I said before of really being able to engage in activities to help promote mood. The biggest metaphor I can give to people is when you go to the gym, you feel better because you're being more active, even if you didn't really even want to begin to go to the gym. Okay. Dialectical behavior therapy, which is a treatment for youth with more severe mood dysregulation and kids who often are suicidal and self-injurious. And it is based on both CBT as well as Zen Buddhism. And then finally, there's interpersonal psychotherapy for adolescents, which is a treatment focused on social relationships and enhancing social relationships for kids, or in both with parents, with their friends, their teachers, everybody in the world. It really focuses on the social aspect of depression. Some kids respond acutely, and I should have said all these treatments alone versus some respond to medication alone, but therapy is generally recommended. This staying on meds 6 to 9 months after remission, that's a general guideline. It's going to depend on your practitioner, what they decide to do. It's really important to say that early intervention increases the likelihood of success in treatment. Do not hesitate to get a kid into treatment as much as possible. And one of the challenges, of course, is how to find treatment. So keep that there are guidelines online and ways to ask friends, family, anybody in their world for recommendations to be able to get assistance. Okay. I am not a psychiatrist, so I'm not going to go into great detail about medication. That is certainly something you can learn more about, but I will give you the general parameters of how this works. So the common medications used to treat depression in youth include SSRIs, which is, you've heard some of these, Prozac, Lexapro, Paxil. There is the black box warning that people hear about on these medications. Again, that doesn't mean that these medicines are most of the time going to elevate any kind of suicide risk. They do have to put them on because it has been shown in some youth. That's basically it. There's other medications, and also there's other SSRIs I did not put on here that are more recent. Medications that are different effects are Wellbutrin, Cymbalta. Sometimes psychiatrists use what are called atypical antipsychotics, which is a very scary name for some people to hear, but Seroquel, Abilify, these are medications that are used also in treatments of depression. Old school medications like tricyclics, you rarely see them anymore, but sometimes people do use them. Okay. And finally, the last piece I'm going to hit today is talking to your child's school. Okay. Now, if you're one of the educators, you probably have some thoughts on how people can approach or how you can talk to parents. And maybe I'll go both ways. But what do you tell the school? So I have a lot of parents who are, when their children are really struggling mental health wise, they're not sure they want to say anything to the school. They're still concerned about stigma, although we've come far in that, not far enough. But I will say to parents sometimes, would you disclose, if you hear a horn, sorry, that's New York City. I will disclose to parents, say to them, would you disclose a medical condition to the school? And so sometimes it gets people to think, and I know the school wants to have the information to be able to help the kid. So we always try to recommend a really collaborative system to help support the child, create the village, be able to have that child be seen by many different people. So I really advise people to talk to a trusted person at school, and then that person can help to develop a plan or get you to the person who can help develop a plan. And so what do you tell the school? I mean, you don't, and again, I know the school officials are probably like everything, but that's not going to be realistic all the time. So you tell the school what the general gist of what is going on. Some parents are very transparent, will tell them everything. So, but it's really important that the school has an awareness. Otherwise, they can't help your child. Sometimes adjustments to the normal routine will be made, like a child is allowed to go in late. Sometimes the depression or the mental health disorder becomes more significant. So you have to create what's called a 504 plan, which helps to get certain services or certain exceptions to typical routine that a kid would need, or an individualized education plan if it's more significant. It's really important to consider privacy and talk to the school about how they're going to keep your information private. The school will probably have a plan for doing that. And again, I really want to emphasize the team approach to this. So I wanted to make sure we hit some of the main points. I already see some questions in the chat. So we are at that point. So first of all, I really thank you for paying attention to this information. We wanted to make sure we had time for questions. I know I didn't cover everything, but the most important thing that I want to express to you is that there are treatments out there for kids who experience and youth who experience these disorders, and that they're treatable and they can be helped. And the earlier on you do it, the better. So thank you for that. So Julie, should I move on to the question and answer session at this point?
I think that would be great. We've got 4 posted in there. So if you'd like to, we've got plenty of time. I think.
Okay. Oops. Okay. Let me do that. All right. So I'm just going to go in order of what I see, and we'll start from there. Any tips on how to encourage a 16-year-old female to complete their homework assignments when they have various medical diagnoses, including migraines, anemia, anxiety, depression, painful menstrual cramps? We are concerned that they asked to leave their independent school program. Yeah, so one of the things I think overall that comes about with significant issues is it's how impacted is their functioning. So first of all, the thing you want to think about with this girl is, what was she like as a student before all this happened? Was she as an attentive student? What motivated her to get her homework done? And what are the barriers to getting her homework done now? Now, they may seem obvious. Well, she has migraines and depression and anxiety, but you want to think about, is it the pain? Is it her thoughts that things aren't going to get better? Is it feeling sad all the time and then she doesn't have the energy or the motivation to do that? You really want to get to an understanding of what is actually getting in the way of getting the work done, because people are going to immediately often start to think, well, they have all this stuff, we have to make exceptions. I would really triage that a little bit first and go, what is actually happening? So let me think if there's anything else. Another thing I would recommend is once you figure out what the struggle is and what the problem is, it's important to, maybe they're going to have to do homework in a different kind of way. Maybe they're going to need to do it in small little chunks, a little bit at a time. Maybe depending on, now this is a 16-year-old, but depending on the person, maybe they're going to need certain motivators to be able to do this. And some kids can do this on their own and independently, and some kids need actual rewards. So you have to think about what will work the most. If you have any other pieces of that question, oops, sorry, I did that again. Please feel free to put more in the chat. Let me go to the chat now and see the next question. How can I effectively encourage my child, 12 years old, to go to bed at a reasonable time? I think being overtired contributes to our mental health challenges. You are absolutely correct. In terms of, we are now obviously seeing even more information and research on how important sleep is. I mean, we know this in scientific community, but all you have to do is watch TikTok and Instagram and you're going to see a ton of stuff on this. There's really important. So I think the thing you have to think about is what is a reasonable time to you and what is a reasonable time to your child. So again, what is actually keeping your kid up? Why do they want to stay up? Really trying to understand it from their point of view. Some kids fight sleep and they just don't want to go to bed. Some kids are worried about the thoughts that they're going to have when they lie down in their bed. And you don't know that they're having those thoughts, but they're really negative, so they avoid going to bed. Some kids are just wanting to stay up and be on the phone. So you have to think about, is the phone getting in the way? So you have to think about what is keeping them up. And then you want to really talk to them about how important sleep is. Why do they want to do this? Perhaps develop a plan with them where they can, if they go to bed by a certain time, they earn a certain reward after a certain number of days. There's a lot of different ways to do it, but you really, again, a lot of people just be like, you have to go to bed. Stop it. Why won't you go to bed? And it's helpful to have more of a conversation, and a 12-year-old can definitely have that conversation. All right. How about telling the teenager that a parent wants them to live? How about reminding of an upcoming event to look forward to in the future? Really interesting question. You have to be careful with that. So the first thing is, there might be some kids where if you say to a kid, if you don't want to live, at least choose to live for me right now. And that can be motivating. For other kids, it induces significant guilt and shame. So you have to be very careful when you say something like that. You have to know your kid well enough to be able to say, like, is that going to be something that's actually going to motivate them because they love me? They obviously love you on it, but because they will connect that, or is it something that's just going to make them feel worse because they're now disappointing you? So really keep that in mind. And then, yes, reminding them of an event to look forward to in the future. Again, something not that you would think that they would like, something that you know they would like, something that you know is important. And sometimes with certain kids, I've said, we call it, I practice dialectical behavior therapy, and we call it irreverence. And the idea is, with certain kids, you can't do this with a lot of kids, but with certain kids, they'll be like, well, you can't go to that event if you're dead, which may sound really direct, but for some kids, it shakes them out of that, oh, this is actually serious. Because some kids, think about it, when you're a kid, you don't actually always understand the significance of what you're saying or what you're actually thinking, like the permanence of death. So it's important to keep in mind that that event needs to be motivating for them. Do you see any role of EEG neurofeedback treatment for depression? There is a research literature on this. I don't know it very well, so I'm not going to be able to answer that in detail. I would say to you that those kind of treatments tend to be when people are what we call treatment resistant to the typical treatments offered that I reviewed before. So there are other treatments, especially, and much more research in adults than in kids, that would help with those things. So I can't get into that, but I think there is a literature on that. Someone wrote transgender information. I'm not sure what you're asking. What I can guess at is what I've mentioned before, is that the LGBTQ population is a significant risk for depression, significant risk for suicidality, significant risk for mental health disorders because of the significant shame and validation that they receive in the world every single day, and many, many other reasons. So I'm not sure what you're asking, but I will acknowledge that that is a very significant, that is a group that is at risk and needs to be given priority.
I think we have time for just one more question.
One more question? Okay. I'm just going to go in order, and thanks, Julie. 7-year-old boy has been biting his nails, and now he is in 2nd grade. He continues with the same behavior and shows aggression and intolerance to frustration. Is he experiencing depression or anxiety? I can't tell you that, because it's possible, but he really needs a diagnostic evaluation to be able to really have a sense of what's going on. I can't diagnose based on that little information, but it's something that has to be ruled out. And do we have time for one more, Julie, or are we really done?
No, you can take one more.
Okay. I work with the school district as a mental health consultant. Frequent issues school staff see as school avoidance. Yes. Parents do not enforce boundaries and expectations of going to school and determine it's not worth the fight of getting their teen to school. Mental health professionals feel they can only do so much to motivate the client to attend school, and the school chooses to drop students after 10 consecutive absences. What advice do you have? Okay, I can do this quick. There's actually some really good treatments out there for school avoidance that people practice. We have a whole curriculum. There's a book, I don't know it off the top of my head right now, you could look it up, but there's a book on treating school avoidance that has a particular methods of addressing this problem that requires collaboration with the schools and requires collaboration with the parents, again, creating that village. And it really is a matter of sometimes making an exception to that attendance policy, or having the kid come in partially for a day to get them back in the swing of things. But there are ways to treat school avoidance. It's tough to treat school avoidance, but it can be treated. And it's easier when it's actually attended to. People don't give up as easily, because it is so easy to give up when school avoidance happens, from many different points of view. So there are treatments out there, so please take a look at them and research them. And that is it.
Okay, and thank you so much. Did you have a resource slide after this one?
Oh, yes, I did.
Okay.
So there's where can you learn more? So lots of different starting off with ADA, but lots of different resources for depression. Some of those resources have that information. Child Mind has that information on school avoidance. And there's lots of different, there's suicide ones here, depression, lots of good information. Psychiatry is ACAP, lots of good information. All right, and this is my information if you want to contact me in any kind of way.